Mr. Chairman, is there an age limit for a knee replacement? What does the literature tell us? That's a photo with different generation, with the name of each generation according to the Britannica Encyclopedia in this side. When any one of us is asked about choose the patient who is doing a knee replacement, all of us will choose the 56, 62, 67, and 70. And we will send these people back home without having knee, the 38, the 43, and the 87. Most of knee replacement are doing in mid-50s to mid-70s. So what about this group, the 40s and the 80s and 90s? An aging nation. That's a statement in the United States in 2014, but it's applied to the entire world. The Census Bureau of the United States saying that the population is aging and the number of centenarians, that's 100-year plus, is reaching 4 million people by the year 2050. So, should we offer this kind of patient a knee replacement? Is there an age limit to have a knee replacement? A lot of literature has been published for the elderly population, and all of this literature is trying to answer a few questions. What's the impact of the age? Is the age a barrier? Should we be restrictive? Can this patient get the same function results? What about the complication? Victoria Brander study in 1979 was the first prospective study applied to the octogenarian with an extensive comparison with a young patient. And they found that a selected octogenarian at no greater risk of death or medical comorbidity from surgery. There is no difference in the length of stay. Octogenarian describe a high level of activity following surgery, and the dramatic gain in function were seen in most disabled patients. Usually, there is a general notion among surgeons that patients around 80 years are a bad candidate for a surgery, and usually they refuse to do a surgery for them. Some study has been reported increased morbidity, increased complication, and many studies show a good improvement in the function, even in the nonagenarians. The improvement in the preoperative optimization of the patient, including the tranexamic acid, the local infiltration, the multimodal pain control, improves the outcome of the patient, whatever they are in their 80s or in their 60s. A study coming from Spain about octogenarian, should we still be restrictive? It's a retrospective study by 2 surgeons for a patient over the age of 80 for the minimum follow-up of 1 year. All demographic data and results show improvement with a normal rate of complication. They are concluded that comorbidity and not the age are the burden for the surgery. You shouldn't consider the age, just consider the associated comorbidity which might affect the result. Another systematic review coming from Journal of Bone and Joint Surgery. It's a study, 10 studies of the nonagenarian and 4 of the octogenarian, and they show that the medical complication is a bit higher, with the surgical complication is almost the same, compared with other results of patients in their mid-60s. About the length of stay was found to be significant in nearly 50% of the study and non-significant in others, with the difference in the length of stay ranging between -1 day to plus 3.1 day, which is not a great deal of increase in the length of stay. Another study asking about, is the age a barrier? It's a very nice study comparing an elderly population, 83 plus 3, the mean age, with the same matched cohort of 69.9 year. The study shows that definitely the survival of the patient is better in the cohort group with the age 69, but the survival of the prosthesis is almost the same, or mostly better in the elderly group over the age of 80, because of the limited activity, of course. As regards the complication regarding the Calvin-Deneuve classification of complication, grade 1 is considered any deviation from the normal post-operative course. Grade 2, normal course altered and it require medication, including blood transfusion or parenteral nutrition. Grade 3, complication require intervention, whether 3A under local anesthesia, whether 3B it's under general anesthesia. Grade 4, life-threatening complication is single organ failure, that's 4A, or multi-organ failure, it is 4B, and grade 5 is death of patient. There is no death in both groups, either the elderly over the age of 80 or the 69. Complication grade 1 and 2 are almost the same. There is a significant difference in grade 3 and grade 4 complication, which is the true complication. But in their studies, they didn't mention, is it grade 4, is it grade 4A or grade 4B? What's the impact of elderly patient upon the outcome? Definitely, patient aged 80 years or more show a significant low, medium, short form 12 physical activity, but it show no clinical meaning. Another study comparing those patients in their mid 80, which we deny to have a knee replacement, with a mid 70s, and it found almost the same demographics, the same score, and the same results, so it should be considered the same. The benefit which we measure in elderly population is the pain relief, the improved joint functions, the enhanced mobility in our score, but another improvement in our patient, which we can't judge, is the independence, the better sleep quality, and psychological benefit of our patient. And the other side of the spectrum, coming the young adult, Kurz et al. Had found that almost 70,000 patients had a knee replacements from 2006 to 2017 under the age of 55. This increase in the incidence of this kind of knee suggests that either the surgeon or the patient expected a more durability and a more function for the patient. James Kinney had his systematic review to assess the total knee replacement in young patient. He had 241 articles, and after exclusion of all criteria, he had only 13 articles met the criteria of inclusion. Definitely, all the scores have been improved with the knee replacement, the clinical score, the functional score, and even the range of motion. But the problem is the complication. As regards the radiography, the non-progressive radiolucency is present between 4 to 30% of the cases, mostly around the patella and tibia, but the progressive radiolucency was not commonly reported in his study. The survivalship is different. It's dropped from 99 to 85 to 96 at the 15 years. The revision for a patellar component failure, instability, infection, and the most commonly reported complication to have a revision. Another study coming to assess the knee replacement coming from Italy. He studied 80,600 patients. He had 238 knee performed in patients younger than the age of 45, with a follow-up of 5.4 years. The young adult receiving this patient, usually a male in his 40, 45 or so, more than half of the patient are other causes rather than osteoarthritis. Cemented BS implant with a fixed bearing is preferred in their study. The survival rate is 93% at 5 years, 91 at 7, dropped to 84 at 10 years, and remain stationary thereafter. At the end of the follow-up at 5 years, there was 21 implant had been revised. The reason for failure, mainly aseptic loosening, followed by septic loosening, and the insert wear. So, what does the literature tell us? Octogenarians stand to achieve a similar gain when compared with younger patients following knee replacement. Well-selected octogenarian had a successful total knee arthroplasty with no increase in wound or surgical complication and no greater risk of death or medical complication from surgery. Comorbidities, not age, are the burden for surgery in older patient. The young patient. Total knee in young patient is still in dispute. This procedure is supported by few reports with a good acceptable result at the midterm follow-up. Draw our attention to the importance of careful selection of the possible candidate. Young patient implied an important rate of revision compared with standard age, which we are operating on. So to make it in a few words, It is crucial to avoid age-based discrimination when considering patient for a total knee replacement. Patient selection is the key. Thank you.